Hello, my name is Dr. Douglas Schottenstein. I am a regular contributor to Pain Clinician and a board-certified neurologist and board-certified pain management physician. The American Society of Interventional Pain Physicians in mid-2009 published comprehensive guidelines for interventional techniques in the management of chronic spinal pain. And the hope with these published guidelines was to develop practice standards based on literature where at times only anecdotal evidence was available in the past. And these guidelines can be currently found in the journal Pain Physician, which I think is volume 12 in 2009. I would sort of like to deconstruct these guidelines and over the next few weeks give my commentary regarding the various published recommendations. Quality of evidence in these guidelines was graded from level 1 to level 3, with level 1 typically representing the highest quality evidence, meaning randomized controlled trials. Level 2, typically trials that are not randomized, and level 3 would typically be opinions of respected authorities. I'd like to first focus on therapeutic epidural injections, and access to the epidural space is divided into three parts in the guidelines: caudal, interlaminar, and transforaminal. And the outcomes for these three approaches are distinct and different. And not only are the entry points or types of epidural injections subclassified in the ACIP guidelines, the causative pathology is then subclassified in the guidelines. So let's first start with caudal epidural injections. Several systematic reviews have evaluated the effectiveness of caudal injections. Dr. Akon and others provided a systematic review evaluating caudal for chronic low back pain of various types, either disc herniation with radiculitis, post-lumbar surgery, spinal stenosis, or chronic discogenic pain without radiculitis and without disc herniation. Level 1 evidence for short and long-term relief of chronic pain was found for conditions of disc herniation, radiculitis, which I think a lot of us would probably agree with anecdotally, and discogenic pain without disc herniation, radiculitis, which I think some of us might be surprised to hear. Kahn also found level 2 evidence for conditions of post-lumbar surgery and spinal stenosis. Again, those would typically be trials without randomization. So based on the data, ACIP makes the following recommendation for caudal epidural steroid injections. Number 1, in managing lumbar spinal pain with disc herniation and radiculitis or discogenic pain without radiculitis, the recommendation is strong. Number 2, the recommendation for caudal epidural injections in managing patients with post-lumbar laminectomy syndrome and spinal stenosis is also strong. What about interlaminar epidural injections? This is sort of the bread and butter of a lot of pain management practices. I think the caudal approach is probably underutilized. The interlaminar approach is probably the most utilized by the vast majority of pain physicians, especially those that are anesthesia trained. Interlaminar injections are divided into lumbar and cervical in the ACIP guidelines. And regarding lumbar interlaminar epidurals, data that was evaluated separately for disc herniation, radiculitis, spinal stenosis, and discogenic pain. For disc herniation with radiculitis, 5 studies met inclusion criteria, but none of the 5 showed long-term relief, which would be defined as greater than 6 months relief. And only 2 showed even short-term relief, which would be defined as less than 6 months relief. For spinal stenosis, 3 studies met inclusion criteria, but only 1 showed even short-term relief, and none of the 3 showed long-term relief. And then finally, for chronic low back pain, discogenic without radiculitis, or without herniation, only 1 study was included. It showed positive short-term and negative long-term results. So sort of disappointing on that end and sort of surprising as well. What about cervical interlaminar epidural injections? Only 3 systematic reviews evaluated the role of epidurals for cervical pain of different varieties. All showed positive results for short-term. 2 of 3 were positive for long-term, and the third, actually, the long-term data was unavailable. It wasn't that it was negative, it was simply that the long-term data was not available. So the ACIP global recommendation, therefore, for interlaminar epidural injections is the following. Number 1, for disc herniation and radiculitis, the recommendation is strong for short-term relief and weak for long-term relief. For spinal stenosis and discogenic pain without herniation, the recommendation is quote-unquote very weak. And the recommendation for cervical interlaminar epidural injections for all considered conditions is strong. Lastly, lumbar transforaminal epidural injections. Transforaminal epidurals, for whatever reason, seem to be the bread and butter of a lot of physiatry pain management practices and getting to be more and more common in anesthesia pain management practices as well. They're also called selective nerve root blocks, and data in the ACIP recommendations came from 4 studies and related to conditions herniated disc radiculitis, spinal stenosis, and failed back surgery. Level 2 data was obtained for short-term relief and similarly for long-term relief, making the ACIP recommendation for transforaminal epidurals strong, sort of across the board. Very good to hear. And ACIP made a point to say that more data is still being compiled for these various treatments, and that the data for our current therapies is somewhat limited, but at least it's better than purely anecdotal evidence, which is largely what we had been going on in the past. I look forward to discussing lumbar epidural adhesiolysis in our next conversation. And if you'd like to reach me to discuss this data further, please feel free to email me at drschottenstein@nyspinemedicine.com. Thank you very much for your attention.